let's dive a bit deeper into the data. So a lot of our discussions based on ADAURA, which is a phase 3 double-blind study in patients with EGFR exon 19 and LA58 are the most common EGFR mutations, good performance status, who had complete surgical resection with negative margins as stage 1B to 3A. 1B defined for the study eligibility as 3 centimeter or more primary tumor. And patients were stratified by stage, type of EGFR mutation, and race. Patients were randomized 1-to-1 after, platinum-based chemotherapy in patients who were agreeable and eligible, appropriate for platinum-based chemotherapy, randomized 1-to-1 to osimertinib versus placebo for planned duration of treatment for 3 years. And primary endpoint was disease-free survival in the stage 2 to 3A patients, but also the 1Bs were also looked at. Secondary endpoints include overall survival, landmark DFS, safety, and NHR quality of life. Now, going into looking at the primary endpoint in terms of disease-free survival, the primary endpoint was met. This is stage 2 to 3A. Really impressive data. Osimertinib, median DFS, 65.8 months versus placebo, 21.9 months. Hazard ratio 0.23. You could see a wide separation of the Kaplan-Meier curve. I would note 84% of patients were disease-free at 3 years, and you could see after the 3 years there is a tick down of the Kaplan-Meier curve. But it does show an impressive benefit, which begs the question for future studies in terms of appropriate length of treatment of adjuvant osimertinib. There was also impressive CNS disease-free survival, hazard ratio of 0.24. You could see here landmark DFS for CNS, 90% versus 75% at 4 years in those patients. And also plenary session at ASCO several years ago. Overall survival was also met in terms of the osimertinib arm having an overall survival benefit, hazard ratio 0.49, and looking at landmark 5-year overall survival, 85% versus 73%. Median follow-up was 61. And there was follow-up of over 5 years on average for both arms. So a meaningful overall survival benefit in addition to a meaningful disease-free survival benefit that has informed our standard of care. In terms of OS, looking at with or without adjuvant treatment, 0.49 for with adjuvant treatment, without 0.47 hazard ratio. And I would also highlight now we're looking more and more into the neoadjuvant setting. So this past year at ASCO, Jamie Chaff presented the NeoADAURA data, which is globalized randomized phase 3 controlled study. This is patients with completely resectable EGFR-mutant stage 2 to 3B, non-small cell lung cancer. Once again, the common mutations, exon 19 deletion and LA58R. Good performance status. Patients were stratified by stage, race, and type of EGFR mutation, randomized 1-to-1 to osimertinib plus platinum pemetrexed chemotherapy for 3 cycles versus OSI alone versus a chemotherapy, platinum-based chemotherapy with placebo. Then there was surgery, and then there was investigator's choice of adjuvant treatment. Primary endpoint was major pathologic response. Secondary endpoints included event-free survival, pathologic complete response, nodal downstaging, and safety. And so in terms of their primary endpoint, the MPR rate was statistically significantly higher with both OSI-containing regimens. For OSI plus chemo, major path response rate 26%, OSI monotherapy 25%, placebo plus chemo 2%. Now I would state, we have a great data with IO of major pathologic response, complete pathologic response, in particular associating with event-free survival. I would say that that's still being established, that connection of MPR with event-free survival with TKI therapy. I think there's a lot more work that needs to be done with that, but it did meet its primary endpoint for major pathologic response rate. In terms of looking, this is interim, so the caveat, this is interim, event-free survival, OC compared to chemo, OC plus chemo, hazard ratio 0.5, OC monotherapy 0.73. You could see the curves there. Of course, many patients got OC adjuvant treatment, as was the standard of care at the time the patient was enrolled, and we still wait for further maturity. Again, this is 15% maturity in terms of reading in to the interim EFS. In terms of safety, the safety data is kind of what we would expect from chemo and osimertinib, and something, but important in particular in the neoadjuvant curative setting. And we also, I would highlight the LAURA data, which was also a plenary session at ASCO several years ago. This is in the locally advanced unresectable setting. These are patients who had stage 3 unresectable disease, exon 19 or L858R mutations, completed platinum-based chemoradiation therapy, patients stratified either concurrent versus sequential chemoradiation, stage, type of EGFR mutation, and race, randomized 2-to-1 to osimertinib versus placebo. Now for LAURA, just to highlight the treatment duration was continued until BICR, Blind Independent Central Review, progression, but otherwise was based toxicity or other discontinuation criteria, but can continue, indefinitely, as opposed to the 3 years for ADAURA. Primary endpoint was progression-free survival by Blind Independent Central Review. Secondary endpoints OS, CNS, PFS, and safety. And treatment had an exceptionally longer progression-free survival, osimertinib versus placebo, 39.1 months versus 5.6 months, hazard ratio 0.16, just very impressive PFS. This is the curve here. At the plenary session, it was even brought up, like the appropriateness of chemoradiation alone without OC in these patients, given the limited progression-free survival at 5.6 months. PET wasn't mandated for staging, so there's a potential of some of those patients may have been upstaged, but nevertheless, the Kaplan-Meier curves are impressive. You could drive a Mack truck through them, and the PFS benefit is quite exceptional. So again, consolidate osimertinib here for unresectable disease, standard of care. And so before we get to Dr. Abu-Ru's presentation, just to follow up on the discussion of this exciting data that's really been practice-changing for early-stage and locally advanced EGFR-mutated lung cancer, I would ask, is the adjuvant 3 years OC appropriate for all patients? What do you do?
I mean, yeah, I think so. I mean, we saw from the study that there's a significant benefit with 3 years, right? So in my practice, I do 3 years. What about you, Julia?
Yeah, I do 3-year course. That's what was studied. I think the biological truth is patients either do or don't have micrometastatic disease. So I think the real answer is probably a portion of patients require indefinite therapy if they have micrometastatic disease. We know when we stop treatment, patients do start having relapses, especially in that first year off therapy. And patients who don't, if we could identify them, don't need any treatment at all. And that's where right now it's 3 years duration. But I think hopefully future technology with more sensitive MRD assays are going to help us. Yeah, are going to help us understand who really needs very long course therapy and who can be spared these sort of very long courses. And that'll become even more pressing when we think about the LAURA courses of treatment.
I totally agree. I had a patient actually was on adjuvant osimertinib, completed 3 years, was doing okay, maybe like a year or maybe like 8 to 12 months. She developed 1 to 2 like very tiny brain mets. So I wonder, this is what Julia is talking about. Like there is a group of patients who will need longer osimertinib, and we need to learn who those patients are.
Yeah, I think what I do in practice, I think it's always that point of 3 years. I do talk with my patients about stopping, and most of my patients have chosen to stop. That's because I've sort of prepared the idea for the entire course that this is a set course of treatment. I do a full restaging. I get a PET CT, I get a brain MRI, because I want to know if they relapse, were they controlled on TKI, and this is an issue of relapse off therapy versus an issue of brewing resistance that I wasn't aware of outside of my CT chest field. So I do restage very carefully before patients come off, and then I increase my frequency of monitoring, especially that first year. I effectively restart the NCCN recommendations on surveillance as if they just had surgery, and I watch closely at that point, and I found that has been helpful to try to mitigate some of this risk. Yeah.
And my follow-up question, are you using neoadjuvant OC, chemo OC, and if so, what situations?
I'm going to jump in on this one. I think it's, the data is very interesting. One, I think we've all understood that in a patient with EGFR-mutant lung cancer where we desired neoadjuvant therapy, chemotherapy is insufficient. I think we've understood that for a long time, but we were stuck without data. That was our option that we had available. So NeoDora is helpful because it gives us safety data about the combination. I think, as we might have expected, it's safe preoperatively. We're not delaying surgery. We're not producing pneumonitis impacting surgical outcomes. I think we're still waiting on maturity of the survival data to understand better whether all patients should get a neoadjuvant regimen versus maybe only those with N2 disease or borderline, resectable but tricky resectable disease where decreased size might spare patients a more extensive resection. I think the strongest argument right now for NeoDora, it really comes from the metastatic setting, right, where once you have an EGFR target, you don't sit around and wait 6 months to start TKI therapy. So I always think about when I find this in my pre-op testing, patients are doing their pre-op surgical clearance, they're seeing anesthesia, they're seeing cardiology, they're going to surgery, they're getting their OR date, they're recovering from surgery, they're doing 3 months of chemotherapy, and then at long last we start the TKI. And that feels like a long gap between target to treatment. So if I do it neoadjuvant, I can find the mutation and start therapy the next week concurrently with chemo, which I think in the metastatic setting is more effective than monotherapy. So I think that is probably the strongest argument in a patient desiring aggressive therapy, but really watching the long-term survival data to understand how aggressive we should be about that.
Yeah, another argument in NeoDora, or another nuance in NeoDora, is do you use osimertinib or do you use chemo-osimertinib, since the results were kind of like pretty much like very close. And I think we need more follow-up on the data in order to be able to tease out that question, because biologically I feel like you will need that stress from chemotherapy in addition to Tagrisso. Although I had some successes with, we shared a case at our symposium of that patient with osimertinib who achieved a path CR. But I think we need a longer follow-up from NeoDora in order to learn, is adding chemo neoadjuvantly going to make a difference?
Yeah, it's interesting. You've asked a lot about, is chemo necessary or not perioperatively? ADORA doesn't answer it, but NeoDora will give us randomized data, so we will understand that in long term for this. Yeah.
Exactly.